Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is unlocking the magic of direct primary care. My co-host and moderator of the chat is Dr. Dan McCarter. Dr. Dan, welcome.
Hey, Faisal, it's good to be here.
How are you doing tonight?
I'm doing well. I'm excited to hear the conversation this evening.
Me too. I am a huge fan of direct primary care, and this is our second guest that we've had on uh, uh, for this topic. And so, without any further ado, let's welcome Dr. Shane Purcell. Dr. Shane Purcell, welcome.
Hey guys, good to see you guys tonight.
Yeah, it's great to have you on. And first of all, when people ask me about direct primary care, you can imagine, we do a lot of medical education about value-based care and restoring the sacred doctor-patient relationship. Oftentimes I'll start off by saying, well, there's a lot of similarities between the fully capitated model, the full risk model, and direct primary care, and it's rooted around the doctor-patient relationship. Getting rid of all the CPT codes, getting rid of all the barriers and all the bureaucracy. I like to think of the direct primary care doctors and the fully capitated doctors as two arrows that have been shot out of the fee-for-service bow. There's no going back. Except the difference is my arrow still has a piece of string attached to the bow. Your arrow doesn't. Isn't that right?
Yeah, we've sort of disconnected. We've done our best to disconnect. As it's a very strong string behind us. So it's hard to disconnect in a lot of ways. And our patients continue to have insurance, and there's a need for insurance. We're not denying
Sure.
there's not a need for insurance because you have serious medical conditions, cancer, serious traumas and accidents, and that definitely require uh, uh, insurance of some kind. But we're in a difficult system right now, and many people either can't afford to have their insurance or they're essentially uninsured. Right? They have a
Exactly. They're
policy,
functionally uninsured with some of these high deductible plans and the high copays.
so they have a policy or they have a card in their pocket, right? But they won't even come get primary care because they're afraid they can't pay the $100 deductible that they know they got to make. So it's
That's,
difficult.
that's right. So I'd like to, before we get into talking about direct primary care, I'd love to hear a little bit about you and your path and your journey.
Sure. Well, I went to med school at Mercer University in Macon, Georgia, and then did my clinicals down in Savannah, Georgia, which was a very good place as a tertiary care hospital, and ended up in Anderson, South Carolina for residency, basically, and sort of never moved. It happens to a lot of residents when you sort of end up where you're at. You get a good group of doctors that you like, and some specialists that you refer to, and you feel settled in. And many residents get married or they have kids, and it kind of you settle into that community where you're at. And that's kind of how we did here in Anderson after completing residency. I did a couple of years of a private practice as an employed physician, and it was full fee for service insurance and the whole bag for a couple of years, and figured out pretty quick, this is not going to work long term. I can't keep punching keyboards and doing paperwork and trying to beg people to get things done. So I took a path as many have. I did urgent care for a while because it was an easy shift. I could go make money, do what I needed to do, get home, with my family. And I took that path as trying to figure out where to go from there. And in 2005, I opened up the first cash only clinic in our community. And it was like a McDonald's basically for medical care. It had a menu board, and you came in and visits were $45, and strip tests were $10, and it's whatever you needed. This is what it cost. And nobody was doing that in our community at all. And obviously 100 years ago, that's the way it was all done.
Sure.
But so I did that for a few years and built up a pretty good clientele of people who were self-pay, fell in between the gap of our local free clinic, couldn't afford insurance. There were laborers, construction people, truck drivers, people that really didn't want to pay for insurance, had a pretty good following. I was still doing urgent care and got a lot of patients from urgent care into my clinic. And so as the urgent care kind of fell to the side, I continued to build up my clinic and ended up buying an old clinic across town that was a rundown clinic, hadn't been open for about 10 years, bought it, refixed it up, and turned it into an urgent care and started doing primary care and urgent care in one building. Again, independently practiced, didn't work for the hospital system or anything. And I had been away from insurance for a while and kind of got sucked back in. Like I said, you said the arrow, that string is really hard to get rid of that. And so I sort of got back into doing more Blue Cross Blue Shield and some of the insurance plans with the urgent care, and it exploded. And we ended up having three nurse practitioners and PAs working with me, and 3 nurses and 3 girls up front and 2 girls in the back just to bill and code. And we were 15 people seeing 60, 75 people a day through the urgent care and workers' comp and primary
Wow.
care and all this.
You were busy.
So it was a big practice going on. And then several things began to happen. I don't know if you remember the old ICD-10, the CD-10 thing,
Sure.
the old Y2K scare.
Yeah.
You're not going to have money for months and months. And that became scary for us. And we looked at even changing our EMR system to better help us function, and made some errors on choosing bad EMRs, which, will get you in big trouble.
Sure.
And so we ended up making a big change. And in 2012, I shut down the primary care side, just did urgent care for a while. And as we got made it through the ICD-10 changes and all, and decided that I can't keep trying to make this work for insurance. That was about the time that Obamacare was taking a full effect, 2014, 15. And the deductibles just kept getting higher and higher and higher for all the patients. And I couldn't make sense of it. Why am I charging $200 for an urgent care visit for a $5,000 deductible patient? They're paying me a $20 copay, and I got to go get the rest of my money in 3 months. It just didn't make any sense when they could just pay me $85 up front, cheaper for them, easier for me. So I just could not make the math work. And that was about the time, early about 2010, 2012 was when DPC, the very beginning of DPC started, with Brian Forrest and Josh Umber and some of these guys who've really started the system, Dr. Doug Farrago. So that was just getting popular. We're starting to see it in Medical Economics magazine, some articles about it. And I said, man, that was what I was doing in 2005, but I didn't have the technology to do the video, the telemedicine, and the monthly membership fees, which is the key for direct primary care, is to have a system where it'll draft out that fee every month. So the technology came about, and I said, man, I need to get back to doing primary care, what I wanted to do. Now this is a system, a direct primary care system. It makes it easier. Then you had programs and EMRs like Atlas MD that will do everything for you.
Yeah.
It'll do the billing, and it'll do the your texting, your email. It just makes it technology makes it so easy to connect with your patients and get them what they need. And so we transitioned to doing more of the primary care in 2015. Helped my current partner, Dr. Amy Cianciolo, who's with me, helped her get started. She had been in the hospital system for 17 years. She really wanted to get out and really focus on patients, because she kept getting written up for spending too much time for patients, spending too much time and not billing enough. So I helped her get out, and we joined a partnership and started Direct Access in 2015, and been going strong. And now we have 4 physicians total, and we have a PA who started with us in May. And we cannot keep the phones from ringing. We have a continued waiting list of people in our community that continue to want access to primary care for transparent prices, for good service, high access, the technology, be able to text your patients, email your patients, videos. We also do dramatically discounted labs and meds in-house, which saves a ton of money for patients. And that's where we're at.